This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is Vascular Disease and Wounds. At any time during the presentation, please feel free to enter any questions you may have. Q&A feature at the bottom of your screen. We'll answer as many questions as we can towards the end of the presentation, and your questions will remain anonymous. Today's presenter is Dr. Michael Peterson. Dr. Peterson is a board-certified vascular and general surgeon and a certified wound care specialist. He's worked at the Mather Wound Treatment Center since 2003 and was named medical director in 2008. Dr. Peterson received his medical degree from the Baylor School of Medicine. He completed his residency in general surgery at Stony Brook University and a residency in vascular surgery at Harvard University, Massachusetts General Hospital. His professional memberships include American Medical Association, Fellow of American College of Surgeons, Society for Vascular Surgery, Wound Healing Society, Medical Society of the State of New York, and Suffolk County Medical Society. Dr. Peterson?
Thank you very much. Good afternoon and welcome to HealthyU. As mentioned, I am Dr. Michael Peterson, a vascular surgeon and the medical director of Mather Hospital's 2 wound treatment centers. Christine and Emily charged me today with presenting a discussion of vascular disease and how that contributes to and is treated for non-healing wounds. I'd like to go to the next slide, please. Many people ask me, what is it that vascular surgeons do? Oh, you're a vein doctor, I often hear. Well, we're more than just vein doctors. We actually diagnose and treat disorders of circulation that involve predominantly 3 systems in the human body. There is the arterial system, the venous system, and the lymphatic system. Next slide, please. First, I'll talk a bit about the arterial system. The arterial system's job is to bring blood from the heart, which of course is the main pump, to the rest of the body, literally from head to toe. And that blood is carrying oxygen from the lungs, as well as nutrients, cellular elements, including our body's immune defenses. And in patients that take medication, even medications are brought through the arterial system to all of the tissues and organs of the human body. And this is imperative for them to function in a normal and adequate way. Next slide, please. Arteries are actually thick-walled structures. They are elastic when in normal situations, they feel almost like a rubber band. They have a thick-walled muscular layer, the same type of muscle that is in our heart. And they are designed to carry blood under relatively high pressure, which of course we measure with those cuff type devices that are put on our arms at the doctor's office. Next slide. Veins, on the other hand, are very different. They are thin-walled structures. While they do have muscle in their wall like an artery, there is much less of that muscle. They are designed to carry blood at a relatively low pressure. If a typical arterial blood pressure is 130 millimeters of mercury, typical vein blood pressure is between 5 and 8 millimeters of mercury, much, much lower pressure. And in order to keep the blood moving, especially against the effects of gravity, veins have built into them little one-way valves that you can see in this graphic depicted to the right side of your screen. These valves are there to allow the blood to move gradually back towards the heart and the lungs and prevent the blood from essentially backing up, or as we call it, refluxing backwards down the leg. Next slide. The lymphatic system, unfortunately, is a somewhat not appreciated system in the human body, but it is of critical importance. The inner aspects of all humans is wet or moist. Certainly, if anyone has ever developed a blister, such as working out in the yard too much this spring, you might get a blister. If you were to pop that blister, what usually comes out is not generally blood, but is typically a clear yellowish type fluid. And that is what is commonly referred to as lymph or tissue fluid. This tissue fluid literally bathes all of our organ systems and every tissue in the human body. And this fluid does in fact travels through microscopic channels called lymphatic vessels. And these come together at specialized junctions called lymph nodes. Many people have heard of lymph nodes because they can sometimes harbor certain types of cancer. And they are also part of the body's immune system, containing a certain type of white blood cell that actually is responsible for creating antibodies, which help the body fight off diseases. Many times when a person has a regional infection, for example, a strep throat, they will have some swelling of their lymph nodes, usually in their neck, as they are gearing up to fight off that streptococcal infection. Next slide, please. But the artery, vein, and lymphatic systems are all connected together. As you can see in this diagram, to the left side, the red represents the artery circulation coming from the heart and the lungs. Ultimately, there are branches that get smaller and smaller, ultimately to the capillaries, which are the smallest of the blood vessels. And their job is to actually deliver the oxygen, the nutrients, take up the carbon dioxide from the tissue beds themselves. But in these capillaries, there is often fluid that also leaks out of the capillaries and is taken up by the lymphatic system. And that fluid circulates back through the lymphatic vessels, all the way back to ultimately ending up dumping into the venous system. Next slide, please. So let's talk a little bit about disease processes. First, I'm going to talk about patients who have problems with their artery circulation, or otherwise known as arterial insufficiency, frequently also called PAD, which stands for peripheral artery disease. While there are certainly a number of different types of arterial diseases that can impact circulation, I'm going to focus today on atherosclerosis. Atherosclerosis is often called hardening of the arteries. And really, for all of us, it is a process that happens to some degree as we get older. It is the development of plaque, lipid deposits, calcium, and even some fibrous growths on the inner aspect where the blood flows of our arteries. And as this process continues, can lead to the development of narrowings, which can restrict the flow of blood. As blood flow is restricted, for example, into the legs, patients at first may notice some pain when walking a distance. And that's because when the muscles are doing work, carrying us down the sidewalk, they require generous blood supply to feed them oxygen and nutrients to allow them to keep doing the work that our brain is asking the muscles to do. When there are some restrictions in the artery circulation, there may be adequate blood flow when a patient is sitting and resting, but when they are walking and the metabolic demands of the muscle increase, if there's not enough blood flow getting to the muscles begin to complain, and what patients feel is pain, typically muscular pain in the muscles of the legs. And we call that claudication. As hardening of the arteries worsens and blockages become more significant, patients can go on to develop ulcerations in their extremities, as well as resting discomfort. And as circulation continues to develop, this can go on to form gangrene, which is really when parts of the body, parts of the leg, foot, or toes actually go on to die. Now, as already mentioned, we are going to be showing some graphical photos. So if you're a bit squeamish, you may want to turn your head to the side. But let's go to the next slide. These are some examples of arterial ulcerations that we may see in patients. And as you can see on the three photos on the right, they are predominantly involving the foot or the toes. These are often painful ulcerations. But the caveat of that is not necessarily in diabetic patients, because diabetics, besides developing hardening of the arteries, they can develop peripheral neuropathy, where their nerves just don't function well and they don't feel pain the way a non-diabetic may. The wounds are typically on the foot. They are often well circumscribed and relatively round. They, of course, are non-healing. And because of poor circulation, they are prone to infection. Next slide, please. Gangrene, as mentioned, is a more advanced form of vascular disease. And this is where the blood supply is not adequate to maintain living tissue. And cells and tissue actually go on to die. This is, again, also a painful process, but possibly not in diabetics. And because there is dead tissue like these black toes you see on these two photographs, infection can set in because the body's immune system is not getting down there either. When infection sets in, gangrene typically turns from a dry gangrene to a wet gangrene, and that can sometimes be a surgical emergency. Next paragraph. Next slide, please. The evaluation of arterial insufficiency generally begins in our offices with non-invasive testing. And this often includes things like pulse volume recordings, which you see an example of one in the photo on the right side of the screen. If you look at the photo, it is looking at the blood flow going down both the left and the right legs. And I don't think you need to have a medical degree to see the waveforms going down the right leg are markedly attenuated compared to the waveforms on the left side, identifying significant PAD or hardening of the arteries. We will sometimes complement these types of tests with in-office ultrasound studies to take pictures of the blockages and the plaques more exactly. We will oftentimes as well get additional imaging studies, such as a CAT scan, in particular a CAT scan arteriogram or CTA, and in some cases an MRI or MRA or MR arteriogram as well, which really defines the blockages much better than we can in the office. Next slide, please. But the gold standard of arterial evaluation is with an arteriogram, which is an invasive type procedure done by placing a catheter or a skinny plastic tube percutaneously into an artery and directly injecting an iodine-based contrast and then taking a series of X-ray pictures. And on the right side, you can see an arteriogram, what is essentially a normal arteriogram. The first picture on the left of that is looking at the abdominal and pelvic region. The white area are the blood vessels, the main aorta coming down to the pelvis. It branches into two blood vessels going down through the pelvis on each side. The middle picture is of the thigh areas, the arteries running down the thigh towards the knee. And on the very right-hand side is from the knee to the foot. And you can see it branches into three vessels in the foot, in the calf on both sides. And in this case, this is a normal study. Next slide. But an arteriogram also allows for an endovascular intervention or treatment to try to correct areas of blockage or disease. And the first way we often try to do that is using a balloon angioplasty. Looking at the picture on the left, it's a graphical example of an artery with a plaque in it. You can see on the left side, as depicted by the yellow material, you can see there is a significant narrowing there under X-ray guidance. And after doing an arteriogram, we insert a balloon catheter into that narrowed segment and then inflate it, as we see in the middle picture. This literally pushes the plaque and cholesterol deposits to the side. We then remove the balloon catheter and have an enhanced lumen for better flow. And if you look at the pictures over to the right, this is an arteriographic evaluation of the same thing. The picture just to the left shows an artery coming down to the knee with multiple areas of narrowing as well as a near total occlusion. And over to the right, you can see post an angioplasty that while still somewhat irregular, we have a markedly enhanced lumen to carry the blood flow in a much more efficient way. Next slide, please. In some cases, however, balloon angioplasty is not enough, and patients can have residual areas of narrowing or stenosis, in which case we will often resort to putting in a stent. A stent is a metallic device that actually pushes and holds plaque out to the side. And you can see a picture of a stent over to the left of the slide. Stents are generally metallic, sort of a woven metal, usually an alloy, and they're often flexible and can be placed in areas where arteries actually move. And if you look at the angiographic pictures A and B, you can see an area of significant stenosis, again, as we just get down to just above the knee level. Looking at pictures C and D, this is after a stent was placed. C is without contrast and D is with contrast. And you can see how the flow lumen is markedly enhanced after the stent was deployed. Next slide, please. And for those blockages that are even more significant, we will often result to using what we call an atherectomy device. Many of my patients call this the roto-rooter technique, where we actually, from the inside of the blood vessel, can go in and scrape these plaques and actually remove the plaque. We can even send pieces of the plaque to our pathologists for analysis. And looking at the three angiographic pictures, you can see in A, an area of very focal but very severe disease in the mid-thigh, just above the knee, where there is essentially a total occlusion. We were able to get through that area of blockage, and using a particular atherectomy device called a TurboHawk, they all have these catchy names, of course, we were able to scrape that blockage and remove it. And you can see the completion arteriogram in panel C, which shows a markedly enhanced flow and almost zero residual stenosis. Next slide. Of course, endovascular interventions are appealing because we can do them percutaneously using mostly local type anesthetics. Many of those examples that I just showed you can be done in an outpatient office type setting or in an ambulatory surgery setting. But in some cases, especially when blockages are more extensive and lengthy, we still have to resort to old-fashioned open surgical procedures. These most commonly are performed with bypass techniques, bypass surgery, not much different than what the cardiologists or heart surgeons do for open heart surgery. We essentially plug in a tube, either using a patient's own vein or in some cases a synthetic. And in the top picture on the right side, I'm showing several examples of synthetic grafts. These are essentially plastic tubes, which can be sewn in above an area of blockage and the bottom end of it sewn in below an area of blockage to carry the blood flow around severely blocked arteries. Certainly, sometimes we'll also remove plaque from arteries and patch them closed using the two patches that you can see in the bottom two pictures. That's called an endarterectomy. Next slide, please. But bypass surgery is major surgery. And with major surgery, there is a higher risk of periprocedural complications. Here's an example of us performing a femoral to posterior tibial bypass from the groin down to the ankle in a patient. And as you can see, this requires taking multiple surgical incisions up and down a person's leg, harvesting out their vein, and then redirecting it by plugging it into the arteries up near the groin, as well as the artery down near the ankle. Needless to say, these surgeries are done in the hospital, typically with general or regional type anesthetics. Patients are typically in the hospital for a week and sometimes longer. And in many cases, especially our older customers, will require some rehabilitation, sometimes in an inpatient rehabilitation stay. And of course, with a much bigger operation and more anesthesia, there is an increasing risk for complications postoperatively. But sometimes, unfortunately, this is what it takes. Next slide. I'm going to switch over to talking about venous disease, and in particular, venous insufficiency. Venous insufficiency develops when there is an elevated pressure in the vein systems. As I mentioned earlier, our vein circulation is normally a low pressure system. having pressures typically of 5 to 8 millimeters of mercury, compared to 120 or 150 millimeters of mercury in a person's arteries. These elevated pressures in our vein systems typically occur from two different potential causes. One is obstruction, and the most typical type of obstruction we deal with is a blood clot. This is sometimes also called a phlebitis or even a DVT, or deep vein thrombosis. And when these clots form, it's a little bit like an accident happening on the Long Island Expressway. If you're ever unfortunate enough to be behind an accident, you know that traffic slows down, sometimes comes to a stop. And certainly it'll take you a lot longer to get home, and you'll likely be late for dinner. In many cases, after these clots even go on to dissolve, scar tissue can form in the veins, causing an ongoing area of narrowing or blockage. We sometimes refer to this as a post-thrombotic syndrome. And veins, being low pressure systems, are prone to having various narrowings and blockages from compression of overlying structures. Reflux is the other cause of elevated vein pressure. And this typically happens when the little one-way valves that I mentioned earlier are leaking, and blood is allowed to back up, typically with gravity, down the leg, causing the pressure behind that leaky valve to go up. Valves can leak in some cases because a person is just born with weak valves that are prone to leaking over time. And in other cases, because the valves may have been injured by a trauma or even a blood clot at some previous point in that patient's life. Next slide, please. Venous insufficiency has a broad spectrum of clinical presentations, everything from spider veins to swelling, discoloration of the skin, as you can see in these two examples. Over time, it can lead to scar tissue developing in and underneath the skin, which results in some hardening of the skin. We call that induration. And in more advanced stages, it can lead to ulcerations in the legs, as well as lymphedema. Next slide, please. Varicose veins represent the most minor degree of venous insufficiency. And these can range from the typical spidery type veins we call telangiectasia, which you can see in the picture to the left, to the larger bulbous type varicose veins that are sometimes even like grapes hanging off a person's leg. And these represent veins that have leaky valves just underneath the skin. Next slide, please. Vein disease is often staged in what we call the SEEP classification, which C1 being the most minor form, or a few spider veins, all the way up to C6, which are the typical patients that we see here at our wound center, which have the swelling, the induration, the discoloration, and of course, the ulcerations in the skin. Next slide, please. Vein ulcerations, compared to arterial insufficiency ulcerations, typically involve the leg and the ankle rather than the foot and the toes. They are often on the inside of the calf, but can be circumferential as well. They are typically irregular in shape, often have a lot of necrotic or devitalized dead tissue on their surface. They are also painful, and because the legs are edematous and often full of water, they are often draining, sometimes even into buckets that the patients bring in with them. Next slide. In terms of managing these wounds, and really all wounds in general, one of the first orders of treatment is to clean that wound and remove any dead or devitalized tissue from the wound surface. And this is called a wound debridement. This is also the most common procedure that is performed here at our wound treatment center. Typically, wounds are debrided from the patient's first visit, and we will often use a topical or local type anesthetic, as well as a small medical device called a curette. And using this curette, we literally scrape the surface of the wound to try to remove the devitalized tissue and allow for the body to ingrow new healthy pink or granulation tissue. And as you can see from the three photos to the right, early on, there is quite a bit of that devitalized yellow slough, as we sometimes will call it, or fibrin. And over time, with serial debridements, we can make that wound nice and clean. You can see on the right-hand side a wound with a very pink, healthy, as we call it, a granulating base. This wound is really primed to heal rapidly and close. Next slide. We will often combine in patients with venous insufficiency and vein ulcerations various types of compression. Compression therapy helps to squeeze the veins and really promote the normal blood flow and reduce that pressure inside the vein system. And there are a number of different ways that we will apply compression to patients that have wounds. Most commonly at the wound center, we will use a multi-layer wrap compression, which you can see depicted in the bottom right picture. That's actually the product that we're currently using. It comes in a small box and has multiple layers, which our nursing staff typically from foot to calf. But we will also occasionally use other types of compression therapies, including Una boots, sometimes even compression stockings or Velcro compression devices. And at the very least, some type of ACE or elastic wrap, again, to try to help reduce that venous pressure, get the swelling down, and enhance healing. Next slide. In terms of surgical management, we, of course, will treat varicose veins in a number of different ways. For patients that have more extensive varicosities involving typically some of the more main superficial veins, we will in many cases perform what is referred to as an ablation or closure type procedure. These are percutaneous type procedures depicted in the photograph on the left, where we access the venous system and then insert that long black skinny plastic tube, which actually heats up and seals off the vein from the inside. It's a procedure that has really replaced what in the early years of my practice we used to call a vein stripping surgery. Vein stripping worked quite well, but it was a bigger operation in that we had to make several surgical incisions on a person's leg, go down to their varicose veins, tie them off, and literally remove them. These newer techniques are much less invasive, primarily using local type anesthetics, and often will combine the ablation procedures with a microphlebectomy type procedure, which again is a percutaneous procedure through a needle poke where we literally disconnect the varicose veins from the circulation. And the results are often very gratifying. As you can see in the two photographs on the right, patients with really extensive varicose veins can come down to almost nothing. For smaller vein issues, we'll often use an office-based treatment called sclerotherapy. This is typically for branch varicose veins that are not connected to the main circulation and are done again percutaneously with a skinny needle. Fluids are injected or foams are injected into the veins, which cause them to scar down and essentially completely go away from the circulation. Next slide, please. For more advanced cases, such as severe arterial severe venous blockages, we will sometimes perform a venogram and even place a venous stent. Venous stents have now been approved in this country for the past 5 years. The middle photograph shows a pelvic venogram. You can see that there are multiple areas of blockage within that vein, restricting the flow of blood from the person's leg to their heart. This particular patient had an extensive blood clot in that area, and that blood clot left behind significant scar tissue. We were able to cross those areas of blockage using an intravascular ultrasound device, as well as contrast with the venogram. We then deployed a stent, and as you can see from the picture all the way to the right, there is clear unobstructed flow all the way up to the vena cava, which is the main highway vein that takes blood to the heart. Next slide, please. Lymphedema is unfortunately the most difficult problem that we have to deal with. Lymphedema is an accumulation of tissue fluid. Tissue fluid that occurs typically because those lymphatic vessels and lymph nodes that I mentioned before are not functioning adequately. This can occur as a primary situation, which may be related to a situation where there's a congenital abnormality in a person's lymphatic system. But the most common type of lymphedema we see is actually secondary, and secondary to a number of different mechanisms, infection being the most common worldwide, but cancer treatments, including the removal of lymph nodes, can lead to lymphedema, trauma, surgery, such as orthopedic surgery, and even patients with advanced venous disease can go on to form scar tissue involving the lymphatic system, as we sometimes call it phlebolymphedema. Lymphedema, like many disease processes, is often staged. Stage 1 lymphedema is really a relatively minor degree of swelling, as you can see in the photograph. More advanced stages, stage 2 and even stage 3, however, can lead to a more substantial disability. Next slide. Patients with lymphedema are really susceptible to significant problems, especially if their lymphedema is not being properly managed. Cellulitis or infections are a very common problem in lymphedema. And as I mentioned earlier, the lymph nodes are really a part of the body's immune defenses. And so in patients with lymphedema, we feel that their immune defenses are compromised. And as a consequence, cellulitis and other infections are very common. But lymphedema can also lead to ulcerations, as you can see in the photograph on the bottom. Patient has substantial stage 3 lymphedema with a large ulceration on their limb. And these can be painful as well as significantly disabling. Next slide, please. In terms of treatment for lymphedema, most patients are treated in a medical or conservative way. Of course, wound care, including debridement, is performed in patients that have wounds associated with their lymphedema. But the mainstay of therapy are various types of compression. Certainly support stockings, as shown in the middle picture, as well as various types of Velcro devices which apply compression, such as the right lower picture, are utilized. There are a number of pumping devices that are utilized. But perhaps, as I like to call it, the Cadillac of treatment is a specialized type of physical therapy. Next slide, please. This physical therapy is typically done by a specially trained lymphedema therapist, oftentimes in a lymphedema treatment clinic or program, as we have at Mather Hospital. The therapy that's performed is a massage type of therapy that is actually called a decongestive therapy or manual lymphatic drainage. And it is aimed at helping to enhance the flow of that tissue or lymph fluid through those lymphatic channels to help open them up and the lymph nodes. These massage therapies are often combined with various types of compression. Early on, especially in our patients with wounds, they will utilize various types of wrap bandaging, typically with a short stretch or tight type of wrap bandaging, as shown in the top photograph, and combined with various types of primary wound care dressings. But I'll tell you, the results are often quite dramatic. As shown on the two photos on the bottom right, patients can enter the lymphedema clinic really significantly disabled with massive edema, and within a few weeks really have a tremendous result. Next slide, please. With regard to surgery, unfortunately, we don't have a wonderful surgical intervention that is currently FDA approved to treat lymphedema. As I mentioned earlier, most of it is treated conservatively with compression and physical therapy. For the most advanced stages, however, there are some surgeries that are sometimes offered. Debulking type procedures, typically done by our plastic surgery colleagues, are really a removal of the lymphoedematous tissue, often combined with extensive skin grafting. This is done in either an open way or utilizing liposuction techniques. But these are bigger operations, oftentimes with substantial blood loss and requiring fairly lengthy hospital stays. And with that, having a relatively high complication rate. And typically are done only in end-stage type situations where patients are beginning to consider amputation of their extremity because they are so disabled. Lymphovenous and lymphatic bypass type procedures have been around for years, but currently remain in an investigational stage. But I will tell you, results from these types of bypasses have been showing increasing promise. And hopefully, within the duration of my career, we will be using these types of techniques on a more general basis. But at this point in time, it is still an experimental type procedure done in university type settings predominantly. Next slide. So in summary, vascular disease oftentimes can and will contribute to non-healing wound situations. Typically, these patients do require a comprehensive evaluation, which in many cases begins here at our wound care center. We will typically utilize standard wound care types of techniques, including controlling their swelling, as well as debridement of their wounds. And in many cases, a vascular intervention is required. Next slide, please. I want to thank you all for your attention, and I would love to entertain any questions.
Thank you so much, Dr. Peterson. That was an extremely informative presentation. If anybody does have any questions, please make sure you put them in the Q&A feature at the bottom of your screen, and we'll see what he can do. Dr. Peterson, after having a surgery to heal one of these wounds, what is recovery time like?
Well, again, it depends on the intervention. As I mentioned, many of the endovascular interventions, which can be done percutaneous, are oftentimes referred to as Band-Aid type surgeries, done with a local type anesthetic. There may be some swelling, some bruising, some tenderness at the insertion sites. But in many cases, these procedures are done as an outpatient through a physician's office or ambulatory surgery unit, or in cases where they have to stay in the hospital, they may have a limited stay, such as an overnight stay. For bypass type interventions, and certainly those lymphedema type debulking procedures, now you're looking at a more extensive recovery. For bypasses, it's not unusual for a patient to be in the hospital for 5 to 10 days. And as I already mentioned, sometimes because of extensive surgical incisions up and down a person's leg, they may even need an inpatient rehabilitation stay before they are safely able to walk and live at home independently. So there's a lot of variability when it comes to the recovery process.
Maybe we could run past everybody exactly how it works to make an appointment at the Wound Treatment Center and what care is like there.
Okay, well, first off, our wound center will be happy to see patients with what we refer to as chronic wounds, which by definition are wounds that have been present for 30 days or more, and especially those wounds that are failing to improve during that period of time. And patients can certainly give us a call here at the Wound Center through Mather Hospital's call center, and they can make the initial intake visit appointments themselves. Typically, patients are seen by one of our intake physicians initially. These are oftentimes medical rather than surgical doctors. They will evaluate a patient literally from head to toe, including their circulation, their vascular issues, their diabetes, metabolic, nutrition, infection concerns. And then patients are typically triaged to one of our treating physicians, most of whom are surgeons, general vascular surgeons, plastic surgeons, and podiatric surgeons, depending upon the main etiology or cause of that individual's wounds.
Great. So we have another question here. Clarifying, certain chemotherapies can cause atherosclerosis. Is that right?
I'm not aware of chemotherapy directly causing or accelerating atherosclerosis. It is certainly possible that some of the newer agents that I'm not familiar with may in fact do that. But in general, atherosclerosis is a complicated process. We're still trying to understand it well. What we do know is that there are risk factors that, when patients have them, seem to accelerate that atherosclerotic process. The number one thing on that list, of course, is the use of tobacco products. But medical conditions such as diabetes, elevated levels of lipid or cholesterol in the blood, hypertension, are also risk factors. We think there may be dietary elements as well. Patients who eat a diet that is rich in saturated fats, that may accelerate atherosclerosis. But there are also genetic elements, which we really cannot control. And some patients are literally just born more susceptible to it. And oftentimes, and we get this a lot with our intake visits here at the wound center, when patients first show up, they will say that they have, parents, they have uncles, they have siblings that have had heart disease and vascular disease and have had angioplasties and stents and other procedures. And certainly those patients are at an increased risk as well.
Okay, great. If anybody has any further questions, please answer them in the Q&A. In the meantime, once you exit the webinar, if you could please fill out the survey, you should be redirected to it. Otherwise, you'll get an email. Just helps us plan our future webinars and understand what you enjoyed about today. If you'd like to view previous content, you could view them on our website at matherhospital.org/healthyu as in university. And I don't see any other questions coming through. So Dr. Peterson, thank you so much for your time today. Very informative presentation. And everybody enjoy the rest of their afternoon.
You too. Have a nice summer. Bye-bye.